Evening all. Meeting call to order.
Investing the call on the president.
Silent prayer. Eh, eh, First, we are going to a session that is current and how to choose a CCB that Vilesh KV. In fact, newer president and declining Dr. Georgie K9, our senior invite Dr. Listen,
My colleagues, today I am privileged to chair this session because my one of my mentor, Dr. Georgie K. Naina, who is considered as the father of nephrology in Kochi, as a speaker. Today we will discuss two topics. One is how to choose a CC and required, and second is the newer strategies in reducing proteinuria and decline in GFR. First, we will consider the first topic, that is how to choose a CCB when needed. We all know that there are various CC travel felodipine. The question is when kidney disease, how which is uh, the- we selecting one CB array of calcium channel blocks. So today it was Tesh KV. Yes, is a nephrologist and transplant physician. He is now working in Ernakulam and also the Palangat, and he studied at just he was done there, and he is one of the best outgoing students in nephrology, and he is the recipient of Amar Gandhi Award for Best Outgoing Student from Bombay University. I invite Dr. Vilesh KV for the presentation.
Good evening, all. At the outset, I would like to thank Physicians Club to consider me for this evening talk on calcium channel block, role in CKD progression. And thank you, moderator, sir, Dr. Jills, for reminding which extra calcium channel blockers of chronic kidney disease. So, the points which I'm going to cover: mechanism of action, the basically calcium channel blockers with a combination of calcium channel blockers and intensive medication. How we could go about that? Nowadays, we have got a flurry of calcium channel blockers, a lot of advantage told to us, and some take-home messages. To start with, the most common cases, 4-year-old male, hypertensive, chronic kidney disease, with a creatinine of 1.8. Clinically, he has got edema of feet and a blood pressure of 150 bar 90 millimeters of mercury. 24-hour urine protein estimation in this patient showed 524 milligrams per 24 hours. He is already on dapagliflozin and insulin and very well controlled sugars. He is on full dose of telmisartan for his blood pressure. Now the question is whether we are satisfied with 150 bar 90. No, we know the current KDIGO guidelines which mention that a CKD patient with hypertension target around 130 by 80 bar millimeter of mercury. So what would be the next anti-hypertensive medication which we should add in such a case? Whether it should be adding a beta blocker, or whether you should add a diuretic, or you should add a calcium channel blocker, or you should try some combination medication, whether you will be happy with a ARB with a diuretic for that edema which he has got, or whether you should also add some calcium channel blockers, whether the traditional ones or the newer ones, depending the history also associated with proteinuria. So when you select a drug, the main things which come in our mind is it should always be case-based, tailoring to the needs of that patient. Definitely cost is a factor in our society, side effect profile of the patient and the drug, comorbidities along with the current scenario. So before going into this, we should dig in a little bit of literature and find out if we are missing on something and how we can come to the conclusion. So calcium channel blocker is basically a class of drugs that block in the heart and smooth muscle, the muscle contractions and basic validation. So there are two types, basically non-pyridines and pyridines. Non-dihydro and the other set of dihydropyridines, which are nifedipine. This slide projects the names of those drugs which are US FDA, but we have got long number of list of drugs which come forward. So basically, how do they work? They reduce the calcium entry into the blood vessels in the heart. So when you look at the dihydropyridines, they basically like nifedipine, amlodipine. They decrease the smooth muscle vascular contraction, thereby causing peripheral artery vasodilation, coronary artery vasodilation, and by peripheral artery vasodilation cause decrease in blood pressure, and that's how it treats hypertension. And coronary artery vasodilation helps in increasing coronary blood flow as a part of treatment of angina, which is also through the benzodiazepine diltiazem decrease the heart ventricle, also accessed in the treatment of the same. And the other side, verapamil, we know that works. Impulse conduction system is rate is decreased. So obviously with that they can be used for the entrant arrhythmias and the treatment of arrhythmias. So with this background, we should also know that there are three or more than three actually L matrix with the clinical drug formulation, the L type, N type and the T type calcium channels. So what I need is basically a high voltage channel with is basically acting a potent vasodilator. N type is basically again a high voltage channel which is basically situated in the sympathetic nerve endings, and they decrease the non-epinephrine release. And the T type voltage channels which are basically and epinephrine vasodilatation, thereby improving the renal circulation. So drugs like nifedipine are mainly acting on the L type. You have got the cilnidipine which both act on L and N type, and we have got newer drugs like ephedrine and azithromycin which act on the L type as well as most of all the calcium channel blockers block the L type channels. Additional advantages are to those drugs which additionally block the N or the T type respectively, which we'll see further. Voltage gated calcium channel, I was told that some DMV residents also attend, so I thought probably for their benefit this was a question in the paper last year. So it's nothing but just an unit which is alpha 1 alpha 2 gamma delta units through the voltage gated calcium entry, and then the action takes place. But looking at also the side effect profile of these drugs, mainly dihydropyridine is related with headache, flushing, lightheadedness, reflex tachycardia, pedal edema, which is dose dependent. On all the other side, with verapamil, you can have constipation. With both these combination drugs, can have gingival hyperplasia as well as decreased heart rate for bradycardia. But some unusual side effects are also to be known that with verapamil and diltiazem should not be combined with beta blockers. They should not be used in heart failures with low EF, sick sinus syndromes, and heart blocks. Some people initially you all remember that short-acting CCBs were taken off because of the high incidence of myocardial infarct, some relation with cancer. But recently, some of the physicians and nephrologists noticed that some patients come with blurring vision and accommodation. So this I would like to know from the crowd if they have seen that. And so many of these youngsters who have been started on drugs like cilnidipine, they report with decreased libido and retrograde ejaculation, which are not mentioned much in the textbooks. So why does this edema? Edema is basically amlodipine causes the vasodilatation of the arteriolar side. The venous side is basically under influence of catecholamine, so it is constricted. So the L channels which help the arteriolar dilatation increases the T capillary resistance, the extravasation of the fluid because of the increased capillary permeability and capillary pressure, and thereby causing pedal edema. So now, with this background of what types of calcium channels we have and what particular drugs do and the mechanism of action and side effects, we would like to know a little bit about renal specificity of this drug as well. So when you look into the renal specificity, this is a glomerulus which is having an efferent arteriole and an efferent arteriole, which we are all aware of, and these efferent and efferent arterioles have T-type channels, which is marked in the purple color, and you got these nerve terminals coming in blue color. So they are the ones which release the sympathetic tone, and the L-type channels, which we already discussed, which is mainly present in the efferent. So when you have a L-type calcium channel blocker like amlodipine, it will cause increase in the glomerular capillary pressure, and it will also increase both in diabetic and non-diabetic patients. When you combine with the patient who's got an L and N type of calcium channel blockers, these are the ones like efnodipine. These three of the patients will have decrease in the intraglomerular pressure, and the L and T type calcium channel blockers, which decrease both because of the T type, there is an efferent vasodilatation as well as the efferent vasodilatation. So it will cause decrease in the glomerulocapillary pressure and thereby reduce the proteinuria. So this is where we have the basics on the renal side. So when you remember the same slide, is you understand that L-type calcium channels are present only in the efferent arterioles. T-type calcium channels are present in both efferent and efferent arterioles, and N-type calcium channels are present in the nerve terminals. I remember this by the code L and T, and I try to say that L is a single, T is a coming third, so it is in both the arteries, and in between is a nerve, that is the N-type channels, which take care of the N terminal, so that we don't forget this afterwards. And this again seen histopathologically, and all these channels have been demonstrated. Why it is important is the as we discussed further, that these channels are present on the cells, the porocytes, and the sympathetic nerve endings, and this effect of using those calcium channel blockers, which will block the respective T cell as well as the N terminal, will produce that positive effect for the renal side. This is again for the DMB residents, because a question on that first slide where we asked for alpha subunit further 10 types, and that question had come in the last year. So I just put that slide. So when you look at any one common particular N-type calcium channel, you can understand that there's a sympathetic nerve from where the norepinephrine is released, which causes vessel contraction, and at the same time you have vascular smooth muscle cell, where also this N-type calcium channel is present. So once you block this, you get the effect of vasodilatation. So once again, to look at other than these effects of vasodilatation and decreasing glomerular pressure causing decrease in proteinuria, what else does renoprotective effects of CCB help us in? So basically, there is a modulation of macromolecular traffic inside the mesenchyme. So we saw that in that picture that mesenchyme also has T-type channels. So the macromolecular traffic is basically the inflammatory cells. So less them of inflammation, less the chance. You also have a mitogenic effect of PTGF, that is platelet derived growth factor, which is increase due to the hypertensive effect on this vessel wall. So that can be also controlled by calcium channel blockers. They are free radical scavengers, and also certain extent they inhibit the endothelin 1 and cause prevention of vasoconstriction also in that way. So these are the other pleiotropic effects of CCB on the renal side. And to specify the calcium channel blockers of T types, the advantage is that one of the pathways is the RUF kinase pathway in the pathogenesis of diabetic nephropathy, and that part is taken care by the CCBT type, and tubulointerstitial fibrosis and decreased epithelial mesenchymal transitions also are when we block the CCBT type. So that's the overall effect we get out of this. So when we go into the newer CCBs, is mainly the dihydropyridines where we are concentrating, because there's nothing come in the non-dihydropyridines. So into the dihydropyridines, come into the first generation where the duration of action was very short, but they had more adverse effects, in which we had our nifedipine and second generation, which was mainly slow release formulations, in which we had isradipine, felodipine, and benidipine. And the third generation, where we had more lipophilic, more stable pharmacokinetics, and very well tolerated in patients of heart failure, was amlodipine. Newer ones being acylindipine and efenodipine, and the fourth generation where your L and N type of calcium channel blockers, which have more stability, reduced adverse effects, and broader spectrum of action, in which we have cilindipine, larcarnitine, and lycadipine. Many of these drugs, which are new in the pipeline, are not US FDA approved. They are from more of Japanese molecules, and probably the lack of randomized controlled trials are the one reason pointed out for their being approved by US FDA. So going to the most important slide, we are trying to understand in this slide that the newer drugs, efenodipine, amlodipine is a trademark drug, cilindipine which came after that, and benidipine. Actually, we can compare these drugs in totality. So when you look at the mechanism of action, we mentioned that the T channels are in the other rho kinase activity and fibrosis and all that is present in eflornithine. So eflornithine is basically an L as well as T type channel blocker. Amlodipine is a plain L type calcium channel blocker. Cilnidipine is L plus N type calcium channel blocker, and benidipine is a combination of eflornithine L type of T type of calcium channel blocker. The half-life is fairly high for T half for amlodipine. The time to reach maximum concentration in plasma is also very high for amlodipine. The T channel sensitivity, as discussed before, is highest for efnodipine and secondary to benidipine. And the negative chronotropic and activity, which is mainly strongly with efnodipine. The reflex tachycardia is not present most of the other drugs, but amlodipine does have it. We have been seeing in practice. Plasma renin activity is also reduced by efnodipine, which we had mentioned because of sympathetic terminal release. Plasma aldosterone level is having a significant reduction in efnodipine, and the ratio of the efferent and afferent, since because we said T-type channels are present in both afferent and efferent, because of which the vasodilatation at both the ends causes decreased blood pressure, and that is the reason why chance of significant reduction in proteinuria in molecules like efnodipine and benedipine, then cilnidipine and amlodipine are fairly plus or minus effect. So this is the set of these drugs, and we will go forward for the renoprotective action which we mentioned before. So because of the T-type channels, the efnodipine has reduced glomerular capillary pressure and increased EGFR in most of the studies. And same way, benedipine is closer to efnodipine in that action. But when it comes to side effects like pedal edema, we are looking more at amlodipine 5 to 16%. So compared to the other drugs like efnodipine, cilnidipine, and benidipine, which you have already seen in practice, and the cause of which we explained before, because of the arterial vasodilation of amlodipine because of the L-type channel. When you look at the use angina, basically other three drugs are recommended, cilnidipine is not. Effect on insulin lowers insulin. The antiplatelet activity is fairly not much in the, but we have the at the same time we are looking at the equivalent doses. So we should know that what dose of amlodipine is equal to ephedrine is equal to cilnidipine and benidipine. If you take a second line, that's 5 mg of amlodipine is equal to 40 mg of ephedrine, which is equal to 10 milligrams of cilnidipine and 4 to 8 milligrams of benidipine. So that comparison is very important. At the highest dose of amlodipine, 10 mg is equivalent to ephedrine 80 mg and cilnidipine 20, and respectively benidine 8 to 16 milligrams. With this, we want to know combination concept, which was one of the options in our treatment, whether that worked in the trials. So the goal is basically albuminuria and proteinuria. Reduction is one of the most important surrogate goals for hypertension treatment because it will definitely reduce the progression of CKD and as well as improve the cardiovascular disease. So GUARD study mentioned that benzapril and a diuretic resulted in greater reduction in albumin compared to benzapril and amlodipine group, understood. But at the same time, they also saw that the decline in GFR was slower with the initial stage studies. The Oscar study mentioned about the same combination and better BP control and low incidence of cardiovascular death in elderly patients. Accomplished trial was the most landmark trial of 2008, which had then part 1, part 2, and part 3. And specifically in this, benzapril plus amlodipine versus a benzapril plus hydrochlorothiazide. So we are comparing a diuretic with a ACE inhibitor along with the amlodipine, and which they found that benzapril plus amlodipine had a better response in terms of renal improvement of GFR and cardiovascular outcomes. That renal impact was noticed in the sub-study which they did with the third part of the trial. Cilnidipine versus other calcium channel blockers in hypertension and proteinuria. So they compared cilnidipine with amlodipine, and they found that cilnidipine group had lower proteinuria than compared to amlodipine group, which is explainable by the block on the L and N channels. As well as amlodipine and cilnidipine were equally effective in the CARTE trial as far as BP reduction is concerned, but it could reduce proteinuria in patients with hypertension and chronic kidney disease when it was put to ARBs. So proteinuric effect of cilnidipine was much higher than amlodipine, but the significance dropped when the patients had very large macroproteinuria. So that was the final conclusion of the CARTE trial. The Amanda studied the newer calcium channel blockers, that is the manidipine versus amlodipine, which is in the pipeline for us. The initial albumin excretion was reduced by 62.7% versus 16%. So again, the L and N channel blockers, L and T channel blockers are having much better response compared to the renal effects. The DIAL study evaluated the effectiveness of the new drug again, lognoparanidipine with ramipril, and they found a significant reduction in urinary albumin excretion at 9 to 12 months. This after study is also another study again trying to look at the same combination of RAS with larnacardinidipine, and the what they found was that the creatinine clearance measured at 24-hour urine collection bettered in the final visit, and there was definitely decrease in proteinuria by the end of the follow-up. The amlodipine dependent trials, they looked into the part of direct study head-to-head with amlodipine, and they found that proteinuria in these patients with chronic glomerulonephritis were compared, and the amlodipine period versus the amlodipine period when the patients were on, they could realize that urinary protein excretion was significantly less when they were on amlodipine period. And in diabetic patients, a significant decrease in estimated GFR was seen in the amlodipine group, but not in the ephedrine group. So definitely ephedrine stood out in comparison with amlodipine. A study evaluated the effect of ephedrine and ACE inhibitors on blood pressure and proteinuria in hypertensive patients. And again, here also, proteinuria tend to decrease in both the groups, but the most important line which I felt in the study was that in those patients whose blood pressure was uncontrolled, even their ephedrine decreased proteinuria. So that shows that ephedrine's decrease in proteinuria was not related to only control of systemic hypertension. Now coming to some benidipine trials, benidipine exerted an antiproteinuric effect to a greater extent than cilnidipine in patients with diabetes. And not only the treatment reduced proteinuria in hypertensive patients with CKD, it also had significant such effect in elderly patients too. So they can be a choice in elderly patients as well. The additive effect, that is when benidipine is combined with the full dose of ARB like 80 milligrams or 10 or 40 milligrams of olmesartan, it definitely showed reduction in albuminuria and plasma aldosterone levels at the end of 6 months, which had an additive effect. So that effect was piled up, or you can say symbiotic, when this drug was added to it. So after these trials and the baseline mechanism of actions and the channels which we looked at, now we come back to our case, who was a diabetic hypertensive CKD with a creatine of 1.6, and we said that he had a proteinuria of 524 milligrams, as well as we mentioned that he had edema of feet. So looking at the aim of treating such a patient would be to control blood pressure, to control proteinuria, to resolve edema. So probably adding a calcium channel blocker would be ideal with a diuretic, probably in this situation, on a full dose of ARB. So you can choose anything. It can be cilnidipine with a small dose of thiazide would have been a cost-effective regimen, or probably if a patient is affordable, I would have chose to add efnodipine in case of cilnidipine to get good control of blood pressure. Also get the positive, effect on proteinuria, which would be enhancing the dapagliflozin which the patient was already taking, which will be highlighted to you in the next talk. Some pointers which come in mind after going through all the trials. For effective BP control, I still believe that amlodipine is far between a better. These three drugs that can be considered. So in comparison to epinephrine and venidipine, the control of blood pressure is good with the above. Whereas proteinuria reduction is considered, then I think epinephrine scores better or equal to venidipine and much better than cilnidipine. Now combine a beta blocker with non-dihydropenins like verapamil for the understandability of SA node and AV node inhibition. You have to be very cautious with use of such drugs in heart failure patients with reduced EF, and definitely avoid patients with intracranial hemorrhage except for nicardipine, which is pointed as can be used. One very significant point and point of use is that in dialysis patients, what will happen to these calcium channel blockers? So most of the calcium channel blockers are non-dialysable because they have protein bound. So that is one good information which helps to beat calcium channel blockers when patients on dialysis have high blood pressure. And as well as in the beta blockers, most are very well dialysable except for carvedilol. So during dialysis, if you encounter a patient with high blood pressure, you can also consider carvedilol as one of the options. So coming to the end of the talk, the take-home messages: calcium block and diuretics and beta blockers are protecting renal function. RAS blockers are best and most effective than calcium channel blockers at reducing proteinuria. But the combination of the pure calcium channel blockers and the RAS blocking drugs are beneficial and more renoprotective than administered ACRB alone. Combining fast-acting blockade drugs like CCB is better than a combination with diuretics for preserving renal function and reducing cardiovascular morbidity, though addition of diuretics will be required. New generation calcium blockers, as we spoke about efnodipine and benidipine, with vasodilator action on both efferent and efferent, because of the T channel blockage and efferent glomerular arterioles have effective effects. Thank you.